So the last not least, we're gonna move to one of the exciting topics that gonna be more famous in the gastroenterologists, not only in Thailand but across the Asia Pacific regions. We're gonna go for the multidisciplinary treatment for the obesity medicine. It's not just the medication at all. We can go to the endoscopic, bariatic, or we can go to the surgeries. We're going to have 3 speakers and 2 moderators. Please come up. Professor Yoshio Yamaoka from Japan and Professor Leong from Singapore. The stage is yours.
Hi, good evening, everybody. I think we are in for a very exciting symposium where we look at a multidisciplinary approach towards obesity management. And I think we have 3 excellent speakers. I'm pleased to first introduce the first speaker, Professor Sanit Wichansawakun. She's an expert in clinical nutrition, and she'll talk to us about the nutritional aspects of obesity care management.
Good afternoon, ladies and gentlemen. It's truly an honor to be a part of this distinguished session. And I am Dr. Sanit Wichansawakun. Basically, I'm physician in nutrition specialist. My topic today will cover about advance in anti-obesity medicine. And this is my disclosure. I have nothing to declare related to this presentation. And my outline today, I will cover 3 parts. First, obesity and its complications, how pharmacotherapy bridges the gap between lifestyle and intervention therapies, positioning of anti-obesity medicine, and concerning point as integral part of chronic obesity care. Clearly, obesity has become a pandemic-level public health issue. The prevalence is higher in Western countries, where more than 40% of adults are affected. Also, the trend is rapidly rising across Asia, including in Thailand. Obesity is not just excess body weight. Currently, it is emphasized as an adiposity-based chronic disease causing metabolic, mechanical, and mental complications, as everyone knows that. And it is one of the leading risk factors for early deaths for our population. The best way to manage obesity is to lose weight. And actually, only 5 to 15% weight loss can help improve health outcomes. And you can see that we can eliminate every complication by losing weight. And also, if the patient can lose more, for example, lose more than 15%, we can see the benefit in terms of decreased mortality, especially cardiovascular mortality, and also can turn to diabetic remission. I would like to highlight one of the impressive results from the Bariatric trial. I think some of you might have heard about this. I would like to show about the impressive result from intensive lifestyle intervention. In this study, they enrolled more than 298 participants into 2 groups based on interventional study and standard care in obese diabetic patients to see how effective of intensive lifestyle to lead them to diabetic remission, and using very low calorie diet based on meal replacement. And the result come that almost 25% of them can lose more than 15 kilograms in intervention group, and a half of them in intervention group can turn to diabetic remission. And if we categorize based on the body weight loss, you can see that in the group that lost more than 15 kilogram, 85% of them turn to diabetic remission. So you can see that for the lifestyle intervention, if we do effective lifestyle intervention, this can help in terms of diabetic outcome and also other obesity outcome. So that's why we need something more than lifestyle change. Because we see that for the overweight management and obesity management, we need something that long-term treatment. So for the lifestyle, most of them can lose better in the first 6 months. It can come to 5 to 9% of mean weight loss during first 6 months. However, many patients experience weight regain or someone can only maintain body weight. In this study, about 2 years after lifestyle intervention, you can see that only 3 to 6% that can maintain weight loss in 3 to 6%. The same as in direct trial, when follow up the patient to 2 years, we can see that the number of patients who have weight loss more than 15% decreased, a half of them, and the number of diabetic remission decreased. That's why the reason happened, because when we try to lose weight and we eat less, the body can adapt to metabolic adaptation. We will decrease in energy expenditure. And in this study, I would like to show that when patients lead to the decreased dietary intake, like in this study, 56 participants living with obesity follow to low-calorie diet after 8 weeks of low-calorie diet. Even though they can lose weight and insulin resistance better in terms of insulin sensitivity, you can see that they have change of the ghrelin hormone and also decrease in GLP-1 and CCK hormone, which cause increased hunger and decreased satiety. And based on regression models predict change in appetite, we can see that after 8 weeks, in the patient who have more metabolic adaptation, decrease more basal metabolic rate, tend to increase hunger and also tend to eat more after they stop low-calorie diet. So obesity is a complex disease. It's not just calorie intake and calorie output, but it is a multifactorial disorder driven by systemic energy imbalance. So we have to manage the patient in terms of lifestyle and also the type of fat accumulation. And this is why we might need something more than lifestyle intervention to help in terms of metabolic adaptations. And for pharmacotherapy, actually, the history of anti-obesity medicine starts from early 1900. However, most of them come with the complication. Most of anti-obesity medication cause cardiovascular complication, and the latest one for the traditional anti-obesity medicine like lorcaserin, it increased risk of cancer and was withdrawn from the market in 2020. And also the traditional one that still have on the market is pentamine that we can use only short term because it had tachyphylaxis. So all of traditional medicine can lose about 5 to 10% and have some complications. So we need to deal with mechanism in terms of control food and appetite. So in terms of food pathway that we have to deal, basically we have to deal with homeostatic system and also hedonic system. So based on this mechanism, we can see that after we eat food, the vagus nerve stimulate from the stomach detention. This can control the feedback from homeostatic system. However, we still need gut hormone after food digestion, and the main character is come from GLP-1, PYY, and CCK that can stimulate hypothalamus and going up to control hedonic system to feel of satiety. And this might be a next key of the new era of anti-obesity medicine. And we found that we have the receptor at the brain and our gut in terms of GLP-1 based medicine. So for the GLP-1 mechanism, apart from control diabetes based on insulin secretion control from the receptor at the pancreas, it also decrease perithalsis, so make the patient feel full earlier and also have the mechanism at the brain to increase satiety. Apart from that, it has the many mechanisms on metabolic outcome. For example, increased insulin sensitivity in the muscle, increased hepatic response to use the glucose, and have the mechanism on heart protection. And we have the new hormone that come as a medication combination with GLP-1 like GIP and glucagon that can decrease complication of GLP-1 and enhance the mechanism in terms of metabolic response in obese patients. So come with the result of new medication. You can see that the number of weight loss better than the past, from 5 to 10% of weight loss. Now it can come up to 15% to almost 20% in some medication. So this might bring the gap from lifestyle intervention that can lose only 5 to 10% and not long term. And for the bariatric surgery that might have some contraindication in some patient, or you have to deal with some cost and also complication to the patient. So for medication, they think we might close the gap between bariatric surgery, interventional treatment, and also lifestyle together. In terms of complication, because the receptor that we have for GLP-1 and metabolic outcome that we see from the medication, apart from weight loss, we can see that they have the mechanism to protect the heart function. So this might be the new medication that can help in terms of metabolic response and no cardiovascular effect to the patient at the old medication. So we have the new term for this kind of medication we call as a Nonthalee, which is a nutrient stimulated hormone, represent a broad treatment category that act on metabolic pathway and also appetite control. And now the FDA approved for GLP-1 and GIP to be the anti-obesity medication. And in the future, we will have many new medication come up like combination, not only GLP-1, but combination with GIP and glucagon like triple agonist retatrutide, which will come to the market. And you can see that the number of weight loss higher. Now it can reach almost 30% of weight loss. So currently, we come to GLP-1 era that can help patients to fight with obesity. We have the evidence based on diabetic care, cardiorenal disorder, obesity, and also in the future, there are many studies come to help in terms of MEFO and some neurological disease and also Alzheimer's disease. This is the study that we have nowadays that something beyond than weight loss from node therapy. For example, prevent diabetes, cardiovascular benefit, decrease mass, and also improve heart failure patients. And for the GI, the study from ASEAN Thai that show the GLP-1 might help in terms of reverse fibrosis in MAFO and also OSA, ONE, and CKD patients. So the pillar of obesity medicine, the pillar of obesity management nowadays, we still need first line management like behavioral therapy, psychological therapy, but adjunctive therapy like obesity medicine and metabolic and bariatric procedure will come together to help our patient. And we can use medication based on their complication and study trial that you can look further for the medication. But what happened with our real world evidence on anti-obesity medications. You can see that we find the number rate of discontinuous from medication. Most of them discontinuous medication like GLP-1 based. In 20 to 50% cannot on medication more than 1 year because of cost and side effect. We can see there are many GI side effects and many patients just continue only lower dose of medication will not give the result as in the trial with the maximum dose of medication. And some complication that we might to concern in the future like eye disease. We see that when patients use more GLP-1 based medicine, there are the studies show that they might have something that we need to concern. For example, severe eye condition. This is a study in JAMA looking in the patient who receive semaglutide and tirzepatide. We see that the prevalence of nerve disorder for optic nerve disorder increase between compare between medication in GLP-1 based and other diabetic medication. Even though the number is not high, for example, like that 2.02 to 2.1%, but there might be something that we need to follow up and concern in the patient who use GLP-1 base. Any challenge apart from GI side effect, we try to add on other medication that can control GI side effect. We can initiate medication and slowly titrate to control this side effect. However, we still need to face with lean muscle loss. For example, when patients lose weight, if they lose more muscle, not fat, this can contribute to sarcopenia and increase risk of all-cause mortality and cardiovascular mortality. When we want to lose weight, it's not just number of body weight, but we want obese patient to turn to healthy person, not sarcopenia person. So we need to concern about this. We have the rule for the patient on GLP-1 or any kind of obesity therapy. We allow the patient to lose muscle mass only, we call quarter rule. So we should lose not more over than 25% of their current muscle mass. This is big number because if we compare to natural history of muscle loss in normal population, like aging process, after 30 years old, we will lose about 3 to 8% of our muscle mass every 10 years, not like 20% of muscle loss. So these are the things that we need to advise the patient to reassure them that they need to eat high quality of protein and enough protein intake, and also adjust like lifestyle intervention, for example, exercise to maintain their muscle mass to prevent them from sarcopenia. And also for micronutrient, that's something that we need to concern at bariatric surgery because obese patients tend to eat unhealthy diet. So it's not good diet that after they lose weight, they might lose some micronutrient and can have further complication from micronutrient loss. Another issue that we need to concern is weight regain after discontinuous medication. Based on the study in GLP-1 based therapy, we can see that after patients stop the trial on medication, about 50% regain from their weight loss. And what will happen if they lose muscle mass, but when they regain fat mass? This can contribute to other cardiovascular and mortality in obese patients again and again. So it's kind of marathon running. So we need to change the patient based on the beginning. We can make adjunctive therapy effectively. However, we still need lifestyle intervention in the journey of obesity care. Because obesity is multifactorial, as I mentioned, there are genetic and also some lifestyle, and they involve with gut microbiota, circadian system. So based on obesogenic exposure, unhealthy diet, unhealthy lifestyle, we need to change the patient back to healthy environment in order to long-term care of obesity management. So not We cannot have something miracle that can help the patient to lose weight without change any lifestyle. So to conclude my talk, obesity is a chronic disease that contributes to adverse health outcome. Standard management of obesity consists of lifestyle modification. We have pharmacotherapy and also intervention surgery that can help the patient. Novel anti-obesity medicine come and also new surgical technique may help increase the outcome of obesity. However, we still need to concern the healthy weight reduction. So we need to implement lifestyle to the patient to prevent them from weight regain and also to bring them to healthy weight reduction. Thank you for your attention.
Thank you for your excellent talk about pharmacotherapy for obesity management. We'll have a common question answer session after all the speakers have spoken because all these are quite interrelated. I'm pleased to introduce the next speaker, Professor Nonthalee Pausawasdi, who will talk now about endoscopic therapy for obesity management.
Thank you, Leong, the chairman, and thank you everyone for sticking around until this late. Happy to be back again since this morning. So I'm going to talk about endobariatric therapy today and tomorrow. I will cover overview of endobariatric and metabolic therapies, or EBMT, and current status and evidence on clinical outcomes, novel approach and devices, and future direction. As you have heard from the prior speaker, that there are several methods to treat obesities, and they have different efficacies. Well, with the invention of GLP-1, as you have heard earlier, I think that pharmacological agent is a strong competitor to the endoscopic procedure because it can reach 15 to 20% of total weight loss. But in my mind, I still believe that endoscopic therapy has a role. It actually fills the gap for patients who are not being able to tolerate medical therapy, but not yet reaching indications for surgery as indicated by BMI. So endoscopic therapy is somewhere between pharmacological therapy and surgery. But I think at the end of the session, I think we're going to come up with a new strategy for obesity treatment. Well, the types of EBMT can be divided into gastric procedure and small bowel procedure. I showed this slide earlier this morning. And the gastric procedure is focusing more on restrictive strategy, whereas the small bowel procedure focuses on metabolic modification. The three pillars of endoscopic bariatric intervention in terms of mechanism. Number one is restrictive, including the endoscopic sleeve, the post, which is plication procedure, and gastric balloon. The other pillar is to regulate hormone, delay gastric emptying, and hopefully in the future we can modify neuronal modulation. Last but not least, duodenal targeting, such as duodenal mucosal resurfacing or DJ bypass, that's going to focus on metabolic profile. So really the key mechanisms would be gastric restriction. You want to remodel the shape of the stomach. You want to get it smaller by about 70%. And you want to modulate the neurohormonal regulation like the GLP-1, PYY. Finally, you want to be able to regulate the metabolic axis going through the duodenal mucosa to control the insulin resistance. And each patient can be different. You might want to end up selecting your patient based on their phenotypes. Just to give you more a visual image of the bariatric endoscopy, gastric restriction versus small bowel leading to malabsorption. With the restriction therapy, we have balloon, different kinds of balloon, and we have gastroplasty technique, which includes suturing and plication. The differences between suturing and plication is that suturing, we do a transmural suture, whereas the plication is just a tissue approximation. For small bowel procedures, we have sleeve, like duodenal sleeve, like just what I mentioned earlier today. It could be a stent, or it could be a space-occupying device. Also, having a strong future is the duodenal mucosal resurfacing, or DMR. That is a device that can burn the duodenal mucosa to allow regeneration of the new duodenal mucosa to help with the insulin resistance regulation. I'll talk more about it at the end of my lecture. Well, the bariatric endoscopy can be used not only for primary procedure, it could also be used for secondary procedure, meaning post-surgical sleeve gastrectomy or bypass surgery. The procedures that we do can be endoscopic sleeve as well, or TORI, which is transoral outlet reduction. I'm not going to go into the details of these procedures, but I just kind of want to have to give you a better idea in terms of how we do the procedure. This video is showing TORI, which is a transoral outlet reduction. So the patient population would be those who have undergone Roux-en-Y gastric bypass surgery with dilated GJ anastomosis. So the idea is to reduce the anastomotic diameter, restoring satiety and reducing caloric intake. You can see that we are burning the anastomosis with APC. And once we burn the anastomosis, we're going to start suturing, and we can do different kinds of suture pattern. Here in the video, we're doing a simple interrupted suture, or you can do purse string. Some people use balloon dilation just to keep the diameter of the anastomosis at about 1 centimeter. Besides from the TORI, you can also do ESG or ROSE, which is revisional obesity surgical endoluminal. And again, this is for those who had surgical sleeve gastrectomy. Basically, you want to decrease the size of stomach even further. So now we have an overview of the endoscopic bariatric metabolic therapy. I want to move on to the evidence of the endoscopic therapy. Well, starting with a restrictive procedure being the gastric balloon, there are different types of balloon, 1 balloon, 2 balloons, 3 balloons, adjustable balloon. Average, the efficacy of the balloon at 1 year is going to be about 10% of total weight loss. This video is showing you how we place the balloon. Basically, it's a catheter that you can insert through the mouth, just like you're putting down an OG. And you can instill water mixed with dye. You can instill it 400 cc's, 450, 500, depending on the size of the stomach. And then you detach the balloon from the catheter, and that's the end of the procedure. Make sure you don't leave the balloon at the pylorus because the patient may develop a gastric outlet obstruction. Again, 10%, not better than pharmacological therapy, but at least it's something. Now, the second procedure, which is a gastroplasty technique, the suturing, plication, as I mentioned earlier. This video is showing you how we do endoscopic sleeve gastroplasty. Basically, the idea is just to reshape the contour of the stomach, make it shorter, make it smaller. You want to reduce the greater curvature of the stomach. We have a tissue helix that would help grabbing the tissue, and then we would just suture and cinch, which is tying the gastric mucosa. Again, the difference between these two techniques is one is full thickness, the other one is tissue approximation. Let's look at the evidence of the ESG. I have to mention this, probably the best randomized control trial we have for endoscopic sleeve at this point is called MERIT trial. Randomized control trial. There's also some meta-analysis study. Basically, based on meta-analysis study, the pool efficacy of total weight loss from endoscopic sleeve at 12 months is 16%. Maybe beat GLP-1 by just a bit, 1%. At 24 months, the total weight loss is at 11%, with a serious side effect of about 2.3%. So really the durability is up to 24 months now. We have the data on that, 10%, not so bad. And no procedure-related mortality, and 85% of the patient improve at least one comorbidities, which is good. This table is just a comparison of the overall outcome in terms of obesity manifested as or characterized as weight reduction. If you compare endoscopic sleeve with placation, with balloon, with duodenal mucosal resurfacing, and with bypass liner, you can see that the suturing procedure or restrictive procedure gives you the best outcome in terms of total weight loss at 12 months. Having said that, though, the adverse event is also the highest. It's not reversible. For the balloon, it's going to be at about 8 to 12%, 10% on average. Very minimal severe adverse event, but most patients will have nausea, vomiting, abdominal pain. The small bowel procedure, the weight loss is not as great, but the primary indication for those are for metabolic modification, which, it has advantage on that. Besides from weight reduction, we also want to improve comorbidities. And several studies have demonstrated that diabetes measured by hemoglobin A1C is reduced by about 1 to 2%. From bariatric endoscopy, the systolic blood pressure is reduced by about 5 to 15 millimeter mercury. And metabolic profiles such as insulin sensitivity, lipid profile, and cardiovascular risk is also improved. Beyond this, there's also some data on liver disease, mainly non-alcoholic steatohepatitis. There are some data on balloon and ESG. As you can see here, besides from weight reduction, you can also reduce the score of steatosis and also the score of fibrosis with some adverse event, mainly abdominal pain from gastric balloon. So with this, you can kind of see that, bariatric endoscopy still has a role. It actually is very efficacy. So that's the global data. What about Thai data? I just want to share with you quickly. This is the data from our hospital from September 2020 up until earlier this year. This is only suturing procedure. We have about over 100 patients. Half of them have primary procedure being endoscopic sleeve. The other half is secondary procedure being ESG after LSG and TORI after bypass surgery. One severe adverse event happened in patient with TORI. That was a case with marginal ulcers. We started doing it, didn't recognize how significant it was. We continued to do procedure, and then the patient had delayed perforation from the increasing size of ulcer, requiring surgery. And then if you look at 1 year data, total weight loss is about 16.4% for ESG. That's also comparable with the international data. At 3 years follow-up, the weight loss continued to maintain at about 14% for endoscopic sleeve, so that's not bad at all. For a secondary procedure, 10% weight loss and 7% weight loss at 1 year and 3 years, respectively. I think that's quite acceptable. And Ting Leong, we combine our data with Ravi from Singapore. This data is kind of old now. It's about 3 or 4 years old. When we started, we were one of the first group using a single channel Apollo device. Usually it's a double channel, but the single channel just got released, so we combine our data with a center from Singapore, and we also got a pretty good results, meaning 14% weight reduction at 6 months and 12% at 12 months. We just wanted to make sure that the single channel is as good as a dual channel. And Professor Suthep, along with the Endoscopy Society, we worked together, published this consensus guidelines on endoscopic sleeve gastroplasty, published on SMJ. If you're interested, you can look that up. And before I go to the last part of my talk, I want to kind of summarize to you how we select the patient for a proper procedure. Mainly, if you want weight reduction, I think endoscopic suturing is the way to go. But if you want to improve metabolic profile, then if you have the ability to do small bowel procedure, that might be an option. Got to be very careful if you want to do endoscopic suturing in patients with severe GERD or reflux disease, because that's going to get worse. You want to treat them before you start doing suturing device. And obviously, post-surgery, tori is preferred option. Balloon, when do we use balloon? Well, it's a very good tool for bridging procedure. Like, for example, if you have a very obese patient who will undergo transplant surgery or any kind of abdominal surgery, weight reduction with balloon is actually a very good option, in my opinion. What happens tomorrow? The future of bariatric endoscopy. Well, I think that we're going to move from purely gastric volume reduction to metabolic modulation, small bowel intervention, combination therapy, meaning bariatric and medical treatment. When we say bariatric and medical treatment, most of the data is on endoscopic sleeve plus GLP-1, and I would touch on that a little bit. The small bowel procedure, this morning we talked about the bypass device, which I would not repeat, but I'm gonna give you a glimpse of the duodenal mucosal resurfacing. Both devices are being studied extensively in the US. And I believe in the future, we're gonna have a simpler and easier suturing device. For EBMT with GLP-1, I just want to give you a quick, quick results. So this is a retrospective study of a 66-patient series. They combined ESG with liraglutide, and what they saw was that there is an additional weight loss by 4.2% when you combine the two together compared to ESG alone. The criticisms about this paper is that, number one, is a retrospective study. The patient selection has a lot of bias. There are lots of confounding variables, and it's not randomized controlled trial, but at least it's an idea that combination therapy might be the future. Duodenal mucosal resurfacing by fracture. It's the idea of this is that you're gonna use a hydrothermal ablation. You're gonna ablate the duodenal mucosa starting from ampulla. You want to make sure you don't burn the ampulla, and you burn it from distal to the ampulla all the way to ligament of Treis, allowing the duodenal mucosa to regrow, and hopefully that would regulate the insulin resistance, allowing patients to become less insulin resistant. And there are some potentials to restore insulin sensitivity. The paper had been published years ago and is an active trial in the US. So finally, I want to conclude that EBMT is effective, is safe. The combination therapy has a promised future. And I think that stay tuned for metabolic intervention, neurohormonal modulation. It could be a game changer in the future. With that, thank you very much for your attention.
Okay, thank you very much for your very excellent talks. So in the final speaker is Professor Suthep Udomsawaengsup. She is now the president of the Thai Metabolic and Bariatric Surgery Society, and also the International Federation for the Surgery of Obesity and Metabolic Disorders, Asian Pacific chapters. Okay, so please.
But thank you very much, chairpersons. And I would like to thank the organizing committee for having this session and having me joining. I think we've been discussing about how to deal with obesity and what options. Dr. Sanit already saying that the exercise and change need to be done, and following with medication, and the gap that Dr. Nonthalee has been helping bridging the gap between indication to surgery and the medication has been already discussed. I myself am Dr. Suthep. I'm a surgeon. I am a bariatric surgeon, actually an upper GI surgeon working very closely with our friends in gastroenterologists. So thank you very much. Let's move quickly. So I've been doing bariatric surgery more than 20 years. So what I would like to emphasize is that we do need multidisciplinary, and I will touch a little bit extended on the how the bariatric surgery does work for the patient. And next, I think I'm going to talk about how to choose the procedure. So next. Now, we know that this is the obesity. It comes with so many comorbidity, especially diabetes, dyslipidemia, and those diseases. So that's why we do need the multidisciplinary care. So let's go forward. This is our team. You can see that including all physicians and teams together. So next. And also, we are a research unit for Chulalongkorn University working on the treatment of obesity and metabolic diseases. Next. This is our clinic. So next. Guideline, extended form, what Nonthalee has shown. So this is our Thai Society for Metabolic and Bariatric Surgery consensus. You can see that BMI above 30.5 with comorbidities, or more than 37. Next. We all know that in US it's been moved a little bit for the indication. That's why this year we actually updated our guideline. But what we can see that the BMI is still the same. Next, and next until we have seen all this. You can see that what we have in our clinic, in our multidisciplinary, the patient will see all the internists and also teamwork, gastroenterologists, pulmonologists. This is in our one-stop unit. And next on your right side, you can see that for BMI above 50, we tend to advise the patient to undergo Leong gastric bypass. For BMI below 50, patient can choose, but mostly it will be a sleeve gastrectomy. Next. Okay, you can go next until next. This is sleeve gastrectomy. Just to share to you, you can see that we remove 85% of the gastric part, and that leave the small pouch of the stomach. This is sleeve gastrectomy, and it's the most common procedure. Next. This Leong gastric bypass, you can see that we make a pouch about 15 to 30 mil, and then we bypass the small bowel, as you can see, 100 and 100 centimeter in Leong fashions. Next. This is our two main procedure. It's all be done by laparoscopic technique. Next. Right now, globally, sleeve gastrectomy will be number one, and more other procedure I will share to you. Next. Now I'm talk about how it works. So go next. It used to be believed that it's because of the size, but actually next it's about hormone. So next, until we have seen another slide. This is what happening. It's about how to moderate the hormone. It's about hormone. For sleeve gastrectomy, we mostly remove ghrelin, and for the Leong gastric bypass, you can see that PYY and GLP-1 is increasing. Next. Next. And this is what happening. We remove ghrelin, which is induce the food intake, or and also we try to increase the GLP-1, as you can see from this slide. Next. Okay, this is our study to show that most Leong gastric bypasses seem to be effective, especially in weight loss. But however, metabolic disease is also the same. This is our randomized controlled trial study. Next. This is just came this month to share a long term of the randomized controlled trial, big study. And then you can see that mostly will be the result. the Rungwai will be most effective, following by a sleeve gastrectomy. For adjustable gastric banding, I would say right now we're not applying for the patient. Next. This is what how we choose, how we match for the patient. You can see that BMI above 50. Those who have reflux or have hilar hernia, or those who have severe metabolic disorder, they will be advised to do room-wide gastric bypass. And if the patient agrees to proceed with a bypass procedure, they need to be regularly follow up. That's mandatory to all patients. Next. And right now in Asia, I would share to you is that right now we have new procedure to share. It's called sleep plus procedure. What we have found that sleep, which the most common in some patients, that doesn't work well. So next. Next. This is also about sleep plus procedure here in Asia. You can see that it is about duodenum, jejunum, or ileum. So those, DJB is duodenojejunal bypass. We cut the duodenum and put the jejunum to be bypassed. So all procedure try to moderate the hormone. And SADI, S and A is single anastomosis, mean they made it by loop, with the loop to be connected. DI is duodenal bypass. By partition, what been found right now, after having a sleeve gastrectomy, they put another limb to the pouch of the stomach. That's called bipartition. So those new procedures been doing, especially here in Asia. So, but we still need more evidence to share with our friends. Next. This is sort of bypasses procedure. As I said, bypass and sleep plus procedure right now, it's considered for those who are more severe obese or metabolic diseases is more severe. So next. This is the evidence. You can see that right now, most of the study will be going on this. Next. I shared to you a little bit about sleep plus procedure by this slide, but anyway, what I would like to show is that you can see total weight loss is about 33 to 36%, even sleeve alone or sleeve with jejunal bypass or low-wide gastric bypass. This is what bariatric surgery would help for the patient. Next. And next. So this is a year follow-up. You can see that right now we are tend to use total weight loss. You can see that 30 to 40%. Next. And this to combine to compare room-wide gastric bypass with other procedures, sleep plus procedure. It's been shown that percent of excess weight loss, hypertension remission, next, diabetes, and A1C level has been shown almost similar effects. So I think we do need a sleep plus evidence to share a little bit more. Next. This is bipartisan. As I said, you can see that is also showing a very good result. Next. Next slide, please. This is to share the evidence of the bipartisan, and you can see that A1C level, it's decreasing to less than 6%. Next. But also you can see that late complication, the complication of having a bipartisan. This is SAGES, mean we put the jejunum connected to the pouch of the sleeve gastrectomy. The most common and the most debatable would be the gastritis, especially by reflux. Next. So you might ask about what happened for long-term follow-up. Right now, we use our recurrent weight gain after sleeve gastrectomy. About 10 to 20% of sleeve gastrectomy might have recurrent weight gain. And you can convert to bypass or do a Lee sleeve or convert to another bypass, which is one anastomosis gastric bypass. next. Or what we have now, that those procedure that will be added to sleeve gastrectomy next. This is all to share that after sleeve gastrectomy, you can do leaf or do DS or do SADIs next. And next, I'm going to share to you next slide, which is next after Leong gastric bypass. Next slide, please. Here it is. So Leong gastric bypass is very effective, but 5 to 10% of bypasses cases may need to do revision. So what we can do is that we call distalization. So I think I share to you our procedure mostly. The most common procedure is sleeve gastrectomy. The most effective right now is bypasses would be Leong gastric bypass or OAGB. But in case of need, after the, we call it recurrent weight gain or suboptimal clinical response, we can add some procedure to make it more effective. Next. This is what we can do added to post-Leong gastric bypass. I think Nonthalee has shown to us very nice how to make the pulse size reduce, how to reduce the gastrojejunostomy size, so that endoscopic would help very much. Next. Now I'm sharing to you what we have done in our society. You can see that bariatric and metabolic surgery, we do need to have more surgeons. We need to have MDT team and also public awareness, as well as patient and family education, also very important. Last but important is about reimbursement, which right now what we have done for the patient is that we have to prepare all factors before we having the reimbursement to be approved. So next. This is what happening here in Thailand. The majority of people will be covered by the National Health Security Office, which been already covered. Next, it's Social Security is also reimbursable, and a small group will be the government employee, which also already reimbursable. We are working very hardly with the insurance company. Half of them are already reimbursement, but the other are still working on the processes. Next. So, ladies and gentlemen, I think same as we have discussed, we do need the multidisciplinary approach, and several modalities would be added. And the process of the treatment is the most important. For surgical treatment, I think sleeve gastrectomy is the most common, following by Leong gastric bypass. And also we prepare those revisional surgery for the patient. Last but important is about public awareness and how to get the process done for the patient. Next. This is our campaign. We call it 100K Obesity Run. We have it done in February. Next. Thank you very much.
Okay, thank you very much. So now we have open to discuss. So maybe first, anyway, here is really only the drug and also the endoscopic or real surgery. So we don't know what is the best, but anyway, for the medications, so usually there is some difference in the efficacy between, for example, woman and man, or younger generation, young generation, or older generation. Are there any difference of the efficacy?
Medication.
Yeah, medication.
Yeah, actually, I think for the medication, they still need subgroup analysis, but we found that for the complications, like in elderly patients who get anti-obesity medicine tend to lose more muscle mass, and this is the thing that we need to be careful about sarcopenia, and compare between obese patient and obese with diabetes and obese without diabetes. we see the efficacy of weight loss from anti-obesity medicine that for the obese without diabetes will lose more than the patient who have diabetes at the beginning. Yes, but I think for the other type, many more research study and more data.
I do have a question for you. So a lot of people now are saying that bariatric endoscopy is dying in the next 5 to 10 years because the invention of GLP-1 and all these very wonderful medications. And obviously, people who can afford it will go for medical treatment, lifelong, by the way. But it's my experience that I think only a small percentage of patients can tolerate that really high dose of medical therapy. Even though the Lancet journal, was that Lancet? Yeah. Lancet published 20% total weight reduction with medication. It's never been my experience that patients can tolerate that high dose of medication. I just want to ask you, what was your experience like?
Yeah, because the medication just come in Thailand this year. So in the past, I think the patient can tolerate at the minimal dose of the GLP-1 at, for example, like for semaglutide, most of them use only 1 milligram, but I'm not sure that because of cost or because of side effect. In Thailand, I think the problem is the cost of medication because we cannot get reimbursement. But for last 2 months that I have experience to use more dose of medication, I think it depends on the individuals. The key of GLP-1 side effect is come from the lifestyle too, because if they know how to eat the food, to stop eating food and also to limit the fatty food, after like 1 to 2 months, they can tolerate with the high dose of medications. However, in terms of the thing that you mentioned about bariatric surgery will die, I think
surgery will be here forever.
yeah, but
It's
I
been
think
here, it
in my
will be here.
opinion, I think it's something that we have to do together, because for the medication, I think it's still high cost, and also I saw like some patient not respond to medication, and there have some studies show that it related to genetics too. They have some genetic susceptible for GLP-1. Like someone might not like respond well on medication to it, kind of like personalized medicine in the future. So it's not like all or none. And I think for example, like bariatric surgery now it get reimbursement. So it kind of like one time, but you cure everything.
Let me add a little bit. I think when medication come and then added, in the global society has been a concern about the bariatric surgery will be not anymore available. But actually, I'm talking about the endoscopic bariatric surgery. I think with medication that would be empower the ability of the endoscopic treatment to the patient, especially for those who are not eligible for the surgery. And it happening for bariatric surgery, especially those countries where the bariatric is already in the mature stage. They have seen that the number of cases going down a little bit. But here in Asia, especially in Thailand, the number is still increasing because we just implement the treatment to the patient. So I think it's going to be the same. Endoscopic bariatric surgery or bariatric surgery would be, having ability to treat our patient. What's your view?
No, I would agree. I think these are all complementary, and eventually it's going to come down to personalized strategy. I think there'll be those who don't respond to medication, and there'll be those who have weight regain after endoscopic procedure. might end up having surgery, or there will be those who have BMI of more than 50, which, would be very difficult to be responding to combined medication and endoscopic therapy. Yeah, Ati?
I have a question regarding GLP-1 medications. I understand that once you stop, patients tend to regain weight back. So what would be your recommendation? How long can you continue it for? And would you recommend re-prescribing them the medication for further weight loss?
Actually, based on medication, they try to to send the message like obesity is chronic disease, and in American Society of Cardiology, they try to use it lifelong because it kinds of some medication that can treat this chronic disease. But in my opinion, I don't think this is a good way to do because it's very high cost, and I think we need something that it's kind of adjunctive therapy. And finally, the patient need to do well on lifestyle change lifelong. And my practice, I tend to use about 6 months and see what happened with the patients. If they can lose more, we can continue and try to decrease the dose when we have the weight plateau and decrease to the smallest dose and then try to stop medication. So for my patient, I try to stop in 1 to 2 years, but in someone they use more than 4 to 5 years, it's still okay. Yes.
Okay, thank you very much. So now the time is over, so we close this section. And thank you very much for a very excellent talk.
Thank you.